Okay, final award of the evening. Truly, all the awards are so special, and I'm really happy to be introducing this award and what it really means to the PCC and to primary care, and I'll be introducing our presenter in just a minute. So the Barbara Starfield Primary Care Leadership Award was established by the Primary Care Collaborative in 2012 to honor Dr. Starfield, recognizing her enduring commitment to the philosophy that all individuals should receive comprehensive, coordinated, and person-focused care. This award is presented annually to an individual who demonstrates exceptional work toward advancing the goals of primary care, and in particular, a strong commitment to person-focused care. Please join me in welcoming David Wethington of Elevance Health to introduce tonight's honoree.
So I was told I have 7 minutes, but as a health plan employee, I've learned a cardinal rule is to waste as little primary care time as possible. So I will be much quicker moving through this. Elevance, formerly Anthem, has had the honor of sponsoring this award for several years. And so we've had a front row seat to the sort of evolving focus of the Primary Care Collaborative. And frequently we've found that it aligns well with what I will say is our best intention as a payer organization in the industry. We do our best to live up to what Ann and the team are trying to advance. This year was really excited to speak with her and learn about sort of the evolving focus on whole person primary care and how to think beyond sick care and how to create innovative models that allow for more community-based care. And most importantly, how do we get funding and support in the right places to do this? So as I took a little bit of time in the week before this to get ready and look at sort of what kind of conversations were going on around whole person primary care, I saw there were 3 questions, right, that Primary Care Collaborative has been asking, right? One is, how do we get focus on the 80% of factors that contribute to health that aren't part of the normal healthcare treatment plan, right? How do we know the things we're focusing on are going to work? And third, and from my perspective, the thing that we have some opportunity to assist with, how do we pay for it, right? When we've identified what works and what we need. So I really think, and I know sort of my leadership at Elevance, we spend a lot of time talking about this. Asaf and I were talking about a clinician I work with who he knows, who shares some of the same philosophy with. Think about what are the key steps to our ability, right, in the industry, not just myself, but our partners at United and then others, to try and support primary care as effectively as we can. And we've kind of been moving forward with what we call the 3 C's, right? One is contracting for outcomes, right? So as a partner to primary care, how can we create payment models that provide for autonomy, flexibility of time, flexibility of how resources are allocated, and minimal paperwork and administration, right, to recognize the financial support that you need. Second, collaborating for success, right? So how can we make information available, particularly on the patients you see that may have had prior clinicians, that may have had specialists you've referred them to that have not referred information that you need back to you, things like that, right? So can we create a nimble and easy way for the primary care network to access information that's relevant to what you're trying to achieve, that's not administratively burdensome, and that's not about sort of administrative rules, but that's about what's important for your patients to be successful. And the third is connecting for partnership, right? So this is how can we use our resources in investment to create digital tools that you can access as primary care providers this is the challenging part, right, for us, in a payer agnostic way, right? So how can we as an industry create tools that make it easier for you to access, to respond, to report, and do the things we ask of you in support of our members and your patients? And, you know, organizations like the Primary Care Collaborative and others really push us, right, to try and be better and to hold to a true North Star, right, that is beyond the needs of shareholders and others, but really keeping our members and your patients at the front of that. And where a lot of our impetus for change, improvement, drive comes from is physician leaders, primary care leaders, frontline workers who, are doing great work and telling us what they need. So I'd written a great intro for Asaf, and then seeing that most of that was in the booklet that was on my seat when I got here. So we're going to skip that and just say, as y'all have read and are aware, his experience is incredibly diverse, both in driving healthcare evolution in the US, but also beyond internationally, South America, Africa, Eastern Europe, right? And as I was lucky enough to sit with him during dinner, we talked about how do you think about within the US healthcare system, system, however you want to think about it, how can physician leaders who have seen and experienced lots of different models collaborate with CMMI, CMMS, with commercial payers, sort of helping us better understand the mechanisms to make it hopefully a little bit easier for you to do what, as our prior award winner just acknowledged, has become a very difficult role to fill in the communities right now. So with that, I'd like to introduce the 2024 Barbara Starfield Primary Care Leadership Award winner, Asaf Bitton.
Well, thank you, David. Thank you to the PCC. Thank you, Anne. It's an enormous, almost frighteningly humbling honor to be associated with an award of peers, but really with Barbara Starfield. Barbara Starfield, who I know I'm not the only one in the room, but who is sort of a hero, mentor, sort of North Star for so many. I never met Barbara Starfield, and that's a great regret in my life, but I can tell you with all authenticity that the way that she put together the work that we do in a tractable, humane, person-centered, authentic, rich and real way was literally one of the reasons that I wanted to become a primary care physician, and that sustained the work across the street and across the globe. So, to even be mentioned in the same name with her is kind of wild. And I think that what she has done and how she has helped us embody and also do something that's so important, which is to simplify and to crystallize what it is that we do so that we can explain it to our grandmother or our neighbor in 15 seconds or less, is so important, because sometimes the barriers that keep us from improving are just the complexities of this messy, inequitable, yucky system. And the clarity of thinking and the moral clarity of action and purpose, backed with the data that she brought, was and has been an inspiration to me. To me, all of this sort of should begin and end with gratitude and kindness. And I think that her work and my goal in the work that we've done, it's funny to get an award as an individual for what is honestly a team-based enterprise around relationship with other individuals. So I just want to acknowledge that. It's just a little funny. I mean, look, we all try to be useful, we try to be helpful, and occasionally we even are. But this is a team sport. And to the extent that any of us is useful, it's that we embody and reflect relationships and teams of teams and service to the communities that we serve and honor. So I just wanted to say that. Kindness and its prerequisites, which are gratitude and empathy, in my mind, have as their outputs connection, trust, and dignity. And I think that beyond the sort of technical brilliance of what Barbara Starfield's work embodied and what we do, what we really do is actually, I hope, we try, bring kindness and love more into the world. Now, you may say, and that's okay if you're cynical, I'm cool with cynical. You may say, what is this guy talking about? It's all about payment and policy, and didn't he do so? It's sort of about that, But I think, as the wonderful mayor told us, it's actually about bringing love and thoughtfulness and justice and accompaniment into and with our communities. In many ways, primary care is the embodiment, the promotion, the institutionalization, the structuring of kindness. That relational element that I see you, you see me. We have something to offer to each other. We will walk this walk together. We've come from different parts of our worlds, but we're here together, and we're here to do something together. Maybe you want to make a behavior change. Maybe you want to have an acute issue met. Maybe you want to have a chronic issue walked with. What we're doing is, yes, we're bringing some technical expertise, but we, our teams in primary care, I say this as a practicing clinician, we are bringing forth that principle of embodying kindness and gratitude into that world. Barbara Starfield is most known for her 4 famous functions that in 15 seconds can succinctly summarize what we do in primary care and for which there is an evidence base, by the way, that's relevant across the street and it's also relevant across the globe. And those 4 functions, I'm going to name them, but I'm going to ask you to see them through the rubric, through the lens of kindness. When we say that I am here for when you need me, we're embodying first contact access. When we say to the person that we serve, I see you and I serve you as a whole person, not as a disembodied mind and teeth and organ system, but I see you as a person in your community. Your lived experience, your history, your difficult history, your family's and community's difficult history. I see you, and you are seen, and you are known. We see comprehensiveness. When we say, we will walk with you and hopefully be useful to you as you enter and exist through your healthcare journey, we coordinate the journey of healthcare. We make it better. And then when we say, we will build through all those activities a healing connection of trust and respect over time. We build these long-term healing relationships. That's called continuity. First contact access, comprehensiveness, coordination, continuity. That's what primary care is. Those are measurable. When those things happen, the benefits of primary care result. To the extent that any of this work and any of the work that I've done has been useful is to translate that central insight with data that is numbers, but data that is stories, to policymakers who need numbers and to policymakers who need stories. And that journey has been an amazing, wild, bizarre, fun, incredible journey with so many of you in the room and with so many partners. And it's helped me understand that it's through the quietly radical work of incremental departure from the status quo of depersonalized, fragmented, inequitable, undignified care toward this principle, essentially, of being seen, being known through kindness. That is the value that we bring. That is the thing that you want to pay for, because you are paying actually for the thing that we see so infrequently in our healthcare system. Yes, when you need a surgery and you need somebody to open you up and not make a mistake and sew you back up, wonderful. But most of the time you need someone who can see you as a person. You need you need teams of people who can see you and know you as true people, can see your histories. So then I want to talk about something that some of you know. Sometimes my role, Anne tells me to get up here or get up in other places and sort of do some diatribe. Tonight's not a diatribe. Tonight's really about the things that I hope matter most. Because we know what's wrong with primary care and what's wrong with the health system. We've talked about that a lot. I want to talk about what's right. You said it earlier. And I want to talk about why I am hopeful and why I want to convince you, if there's one thing I can share with you, is that hope is a strategic imperative. Hope is a discipline to be cultivated. Hope is something that is not optional if you wish to see any change in this world. Now, hope is not blind optimism. It's not a refusal to face hard facts or hard truths. Because optimism, like pessimism, its nasty cousin, is a forecast. It's a prediction. Hope makes no forecasts or predictions. Hope is rather about facing the reality of the facts and then trying to change them. I didn't say always successfully changing them. Actually, most of the time it fails. But at least you try. Because optimism misconstrued as a refusal to face facts, but hope faces them for what they are in their gnarliness and nastiness, and then says, let's try to do differently. And I really want to say that I see the work of the people in this room, through the PCC, through all of your work on the front lines of clinical care, the front lines of policy, is you are realists. We're not talking about pie-in-the-sky things and fairy tales and rainbows. We are talking about the imperative to see things as they are and still act. And this is a room, and primary care is a group of actors, people who face difficult odds in pediatrics, in family medicine, in internal medicine, and act despite. And I want to really encourage you to keep being hopeful, being realistic, but know that the seduction of pessimism only impedes our ability to be able to be change makers. We cannot be pessimistic. We can hold these multiple truths. Primary care is in peril. We don't have enough resources. The communities that we serve are in pain. And we can also hold the truth that we have the ability to act and to change and to work with our partners to improve. Those are all true. And I want to also suggest that there's something even deeper or more challenging than pessimism, which is cynicism, something that DC does really, really well. So cynicism is even more destructive because cynicism, I would argue, is the luxury of the privileged, who neither can nor need to see a way forward or a change to happen. Maybe they even benefit from a status quo that doesn't work. I reject that. I know you reject that. It can be easy to fall into that trap when we get hopeless, but hope is the antidote to cynicism. And if cynicism is the luxury of the privileged, I would argue that it's our privilege to serve the patients and communities that we do, and our responsibility to them to not be cynical, because they can't afford for us to be cynical, because we have too much to walk with them in their world. I went into primary care because of amazing people. I stay in primary care because of amazing people, because of teams. I think that I stay in primary care, and I think that many of you do too, because of kindness, and because kindness is maybe the only sensible response to the expanse and challenge of being a human being in these days, these difficult days, and that we can embody that in our work. I think that we often overestimate and are too impatient with how much change can happen in our world, in our field, in 2 years, and then we get pessimistic and hopeless. But we often underestimate how much change does happen through our collective efforts in 10 years. And I think that PCC embodies that. If some of you who were here 10 or 11 years ago remember those days, we were talking about things like, well, maybe we will ask for shreds of this, or we'll have a little bit of quality bonus there, or maybe we'll start to work in teams. The world has fundamentally changed because you have changed it. You have ground forward. You have shown the alternate realities on the ground. And I think we reflect that in both the policy environment that's so fundamentally different than it was, but also the practice environment, which is really, really difficult, but is also really, really convergent on what we need to bring advanced, thoughtful primary care to all. We know the playbook is convergent, it's emerging. We talked about it all day, and that's wonderful. It's in National Academy reports, it's in your daily work, it's in the payer playbooks, it's in the provider playbooks. The patients will tell us if you ask them. Now the work is to do it. And in order to do it, we have to be kind, empathic, thoughtful, and grateful. And we also have to be sharp-minded. I laugh, and some of you have heard me say, primary care sometimes is too nice. Sometimes we're sort of act like we're a bunch of fuzzy bunnies. We're so friendly, and you mentioned it. We're too nice to talk about the money, to talk about what we need, to let everybody else sort of take the, push the sharp elbows in primary care. Well, okay, you're right. We'll be all right. No. And you have said that here, and you will continue to say that. If for no other reason than the patients in the communities that you serve, demand what you need. Fight for it. Say it. And be as avid and aggressive for the right reasons as some of the wrong people for the wrong reasons are in this healthcare system. Your communities deserve that. You owe them that. No fuzzy bunnies. Don't leave here saying that you can just be friendly and we're just too nice. No, that's actually pessimistic, bordering on cynical. Say what you need, go get it. The reality, and I'll end very shortly, the reality of being privileged to do so much of this global work is the following. As a sort of almost primary care cartographer, like I get to map out really cool parts of primary care all over the globe. Here are the central findings. There's no healthcare system that's worth anything in the world that doesn't have a really strong base of primary care. Do you know that? Like, it doesn't exist. Find me one if that's wrong. I hope to. That would be great, but it doesn't. There's no healthy system that serves its communities, that controls costs, that doesn't have a very strong primary care system. There are a convergent and not too complicated set of best practices around praying prospectively for primary care, using teams, using data, and having alignment between primary care and public health. That's the playbook. There are details underneath that playbook, but that's what we did when we brought this work to the World Bank, to the WHO, to the Gates Foundation, and they said, what is this whole primary healthcare thing? You've been arguing about it for 40 years. And we said, honestly, Barbara Starfield tells us the route forward. You do those 4 functions, you measure them, you embody kindness and service in your systems, and good things will happen. Then you figure out who you're doing that for. You're first doing it for the communities you serve, but you're also mapping the gaps in the system for ministries of finance, for ministry of health, and on one page you show them what works and what doesn't, and then you enable a cycle of improvement. The convergence is incredible. That should give you so much joy and wind in your sails that you have the playbook. The playbook is relevant in Costa Rica. The playbook is relevant in Compton. The playbook is relevant in Chicago. The playbook is relevant in rural Nebraska. So now we have to do it. And I think that's the exciting part. That's the part to be hopeful. None of this work happens without teams and teams of teams. I am so grateful to my primary team, which is my family, my wife Liz, my 2 daughters Maya and Talia. I'm grateful to all of the incredible people who have mentored me in my life, who from the people like Rachel Naomi Remen and Steve McPhee and Steve McGarvey in my medical school days before I didn't even realize that I wanted to go into primary care, to my clinical mentors Bev Wu and Jane Silman at the Brigham, to the most primary care oriented surgeon I've ever met, Atul Gawande, who has been a partner and friend in our endeavors to improve health systems at Ariadne Labs, to Russ Phillips, to Rich Barron, to my entire team that I get to work with on a daily basis at the South Huntington Primary Care Clinic that we all founded together, to my team at CMS and CMMI, some of which are here, Doug Jacobs, Bruce Fink, Purver Wawal, Liz Fowler, Pauline Lappin, so many others, to the team at PCC, the board, and Anne, the teams in the global work, our teams at Ariadne Labs, team members and wonderful primary care champions and colleagues in this room, so many to name, but I want to really give special shouts out to Bob Phillips and our teaming together over the years and our mischief making. Fellow Boston-based team members, Catherine Gergen Barnett, other mischief makers who say the things that need to be said when they need to be said to those that need to hear them, to Susan Edgman-Levitan, to Chris Kohler, and so many others. I could bore you all night long, but we have to practice gratitude because I said at the beginning, we start and we end with gratitude. We start and we end with the idea that this is about the embodiment of kindness into our healthcare system, the rejection of a depersonalized status quo, and the incorporation of what I think Barbara taught us all, which is how to live with joy, kindness, and promotion of dignity in the world. And I'm just so grateful to be here with you. And remember, it may be kindness and depth of gratitude, but it's a fierce kindness. And go be fierce and go advocate for your communities and get what we need to make health better in this country.